Assalamualaikum and good evening. My CDE topic is about regenerative endodontics. Management of immature permanent teeth with necrotic pulp. Traditionally, immature permanent teeth with necrotic pulp and apical periodontitis were treated with apexification procedure using calcium hydroxide and apical MTA plug to induce apical hard tissue barrier formation. This is a method to induce calcific barrier across an open apex of immature tooth by formation of osteocementum or bone-like tissue. Apexification can be done by using two material, either calcium hydroxide or MTA. Apexification with calcium hydroxide takes a longer time of the treatment, and it involves multiple visits, and it is also proven that apexification with calcium hydroxide increases risk of tooth fracture due to long-term application of calcium hydroxide. Apexification with MTA is much better when we compare to calcium hydroxide in the sense of it only takes one or two step apexification, but it is proven apexification with MTA neither strengthens the root nor promotes further root development. The root remains thin and fragile. This is a picture of apexification that is done by using calcium hydroxide and also MTA. We can see at the apical end there is a formation of the calcific barrier. Sadly, apexification cannot restore the vitality of the damaged tissue. Neither can it promote root maturation, which means by thickening of the root canal wall and also apical closure of immature permanent teeth with necrotic pulp. In the year of 2001, a new treatment option called revascularization was introduced. What is regenerative endodontics? It is a biologically based procedures designed to replace damaged tooth structure, including dentin and root structures, as well as the pulp-dentin complex. Regenerative endodontic aim to regenerate the pulp-dentin complex damaged by infection, trauma, or developmental anomaly of immature permanent teeth with necrotic pulp. Are all immature permanent teeth with necrotic pulps indicative for regenerative endodontic? Initially, regenerative endodontic is recommended for teeth with necrotic pulp and an immature apex, but some teeth with immature apex and necrotic pulp may be suitable for regenerative endodontic, while others are suitable for apexification with MTA. As we can see the picture here, if the root development of a tooth is in the stage of A, B, and C, whereby stage A is it has stage 1 where there is less than half of root formation with open apex, stage 2 half root formation with open apex, stage 3 2/3 of root development with open apex, they are suitable for regenerative endodontics because of the short root, thin canal walls, and wide open apex, as apexification has no potential for root maturation. However, if you see the figure D and E, the root are nearly completed root formation with open apex. They can be managed with either RET, regenerative endodontic, or apical MTA plug and root canal filling because the canal wall has enough thickness and strength. Regenerative approaches in endodontics. There are various regenerative approaches tried over these years. However, revascularization is well documented and is easy to perform and less expensive. Other methods are still in various experimental stages. Regenerative approaches in endodontics, we have several. First, we have root canal revascularization, postnatal stem cell therapy, pulp implantation, scaffold implantation, injectable scaffold delivery, three-dimensional cell printing, and gene therapy. First, we have root canal revascularization. Of course, case selection is important. The tooth with necrotic pulp in immature apex, the pulp space is not needed for post and core or final restoration. Patient must be compliant, and patient must not be allergic to medicament or antibiotic necessary to complete the procedure. During the first appointment, we do isolation, copious irrigation with sodium hypochlorite, and we need to use a lower concentration of sodium hypochlorite, as it is advised 1.5%, and also irrigate with saline. It is we have to take note here, the irrigation needle need to be positioned above 1 millimeter from the root end. And also we dry the canals using pepper point. Then we place calcium hydroxide and place a low concentration of triple antibiotic paste in 1:1:1 ratio of ciprofloxacin, metronidazole and minocycline to a final concentration of 0.1 mg per milliliter. Then we seal with 3 to 4 mm of temporary restorative material. We review the patient back after around 3 weeks. We assess the response to the initial treatment. Then we again do isolation, copious irrigation with EDTA, 17% EDTA, and then we dry the canal with pepper points. Now we need to create bleeding into the canal system by over instrumenting, and we need to stop the bleeding at a level that allow for 3 to 4 mm of restorative material. Then we need to place a resorbable matrix over the blood clot, and also place MTA or calcium hydroxide as capping material. Then 3 to 4 mm layer of glass ionomer. Then we do follow up. We need to see clinical exam and radiographic exam. It is a very good sign in clinical exam where patient experience no pain, there's no soft tissue swelling, no sinus tract, and there's positive pulp vitality test response. Also, in radiographic examination, when we see resolution of the apical radiolucency, increased width of the root walls, and also increased root length, is a very positive sign that our revascularization is a success. This is a figure showing how revascularization, a procedure of the revascularization. In picture A, we can see a immature tooth with necrotic pulp. B, we're stimulating bleeding by over instrumentation. C, we can see that blood flows into the canal to form blood clot. Then D, we seal it with MTA and also permanent restoration, coronary restoration. E, we can see there is regenerated pulp and also continuous root development. Second, we have postnatal stem cell therapy. This involves placement of postnatal stem cell into disinfected root canal for regeneration of lost dental tissue. Postnatal stem cells may be sourced from umbilical cord blood, peripheral blood, bone marrow, body fat, and other body tissue like pulp tissue of the teeth. The drawbacks of the postnatal stem cell therapy includes low survival rate of injected cell, and there is slight chance of the cell to migrate to different part within the body. Third, we have pulp implantation. The concept is based on growing the cells in biodegradable membrane filter. It was reported that there is formation of tissue similar to the natural pulp when pulp cells are cultured in vitro on polyglycolic acid. It was observed extracellular matrix expressed in immunocompromised mice when PGA, polyglycolic acid, was seeded with pulp cells and implanted into subcutaneous spaces. The advantage of pulp implantation is ease of growing cells on filters within the laboratory. They exist as collective sheets which are more stable than unconnected cell, and it can be easily injected into empty disinfected root canal system. However, there is a need for specialized procedures to ensure proper adherence of cell to root canal walls and handling fragile filters. For we have scaffold implantation, pulp stem cell may be ordered into a three-dimensional arrangement that can sustain cell organization and vascularization. This can be consumed using a porous polymer scaffold, which is seeded with pulp stem cell. The scaffold should contain growth factor that aid in proliferation and differentiation of the stem cell. Scaffold can either be synthetic or natural. Synthetic such as polyester material like polycaprolactone, polyglycolic acid, polylactic acid. Natural can be from collagen, chitosan, fibrin, glycosaminoglycans. The scaffold may also contain nutrients promoting cell survival and growth. For example, we have dentin chips that stimulate reparative dentin bridge formation in teeth with exposed pulp, and also it acts as a reservoir of growth factor, thereby acting as a matrix for pulp stem cell. Fifth, we have three-dimensional cell printing. This is a rapid prototype of computer-aided 3D technology in which cells are dispersed layer by layer using an inkjet-like gadget in a 3D hydrogel. This technique facilitates precise positioning of stem cells, creating tissue that mimic the natural tooth pulp. The shortcoming is difficulty in symmetrical spatial arrangement of pulp tissue in an asymmetrical apicocoronal portion of the root canal. 6. We have gene therapy. This is a new field in regenerative endodontics. Attempt focuses on delivering genes that are capable of matrix formation and mineralization into pulp space that will promote tissue repair using vectors. Now we have factors that affect the result of regenerative endodontic treatment. We have size of the apical diameter and root canal disinfection. Size of the apical diameter. In previous study, it was concluded if the apical foramen of the tooth was smaller than 1 mm, then revascularization, the result is unpredictable. Nevertheless, apical diameter of 0.5 to 1 mm attained the highest clinical success rate, because it was later proven that the typical size of human cell ranges from 10 to 100 micrometer. Accordingly, osteoblasts, cementoblasts, periodontal ligament cells, and all other cells can easily enter the canal space through the apical foramen even if it is smaller than 0.5 mm. Root canal disinfection. Preservation of stem cells is important in regenerative endodontic. If infection is not under control, not only regeneration will not occur, but also repair will not occur, because the disinfection in the canal will cause damaged tissue forming cell as well as stem cell in the periapical tissue. Pro-inflammatory cytokine such as interleukin, TNF-alpha, they are capable of inhibiting stem cell to differentiate into tissue committed somatic cell for regeneration or repair. Therefore, intraradicular infection should be controlled for regeneration to occur. Antiseptic irrigant. Sodium hypochlorite is the most commonly used antiseptic irrigating solution in root canal therapy. Sodium hypochlorite with concentration of 1 to 6% have been used in regenerative endodontic. According to AAE, they recommend the use of 1.5% sodium hypochlorite followed by 70% ETA. Based on the studies that shows the cytotoxic effect of sodium hypochlorite on survival of stem cell from the apical papilla in vitro rather than on killing of the intracanal bacteria in vivo. ETA, ethylene diamine tetraacetic acid. ETA is a chelating agent whereby it removes mineral layer in conventional RCT and release of growth factor from dentin matrix in regenerative endodontics. It has weak antimicrobial activity, and ETA acts to demineralize the dentin and expose the dentin matrix to release growth factor. ETA conditioning of the dentin will promote adhesion, migration, and differentiation of dental pulp stem cells towards or onto dentin. A final rinse with ETA before creation of blood clot is advised. Calcium hydroxide, it has good antimicrobial property, and also it has high pH level, which is 12.5 till 12.8, which is not a favorable environment for bacteria to survive. It can also hydrolyze gram-negative bacterial lipopolysaccharide. It was reported when calcium hydroxide was radiographically restricted to the coronal half of the root canal system, the percentage increase in the dentinal wall thickness was 53.8%. Antimicrobial paste. We have triple antimicrobial paste in the ratio of 1 to 1 to 1, mix of ciprofloxacin, metronidazole, and minocycline. And it is a raised concern that minocycline causes crown discoloration. Then we have modified triple antibiotic paste, ciprofloxacin, metronidazole, and cefaclor. We also have double antibiotic paste, ciprofloxacin, and metronidazole. Growth factor and regenerative endodontics. Growth factors are polypeptides produced by immunoinflammatory cells. They regulate cellular function, including survival, proliferation, migration, and also differentiation. Disinfection irrigants and medicament used in regenerative endodontics influence growth factor release from the dentin. During regenerative endodontics, dentin conditioning agent is used to liberate the entrapped biological cues from dentin matrix before apical bleeding is evoked. These molecules can direct the behavior of the cells mobilized into the root canals by apical bleeding towards pulp regeneration. Among the growth factors released from the dentin matrix, fibroblast growth factor, platelet-derived growth factor, and many other growth factors promotes dentinogenesis. Blood clot. Induction of intracanal bleeding in regenerative endodontic is to provoke periapical tissue bleeding into canal space. This is to provide a blood clot as a scaffold and to introduce platelet-derived growth factor and mesenchymal stem cell into the canal space for possible pulp tissue regeneration. It was believed that the stem cells induced into the canal space were from apical papilla. Platelet-rich plasma and platelet-rich fibrin has been used as a scaffold instead of a blood clot because they are rich in growth factor and might help improve regeneration of pulp dentin complex. However, now it has proven that no evidence-based study have demonstrated that they could improve regeneration of dentin pulp complex. Is root maturation predictable after regenerative endodontics? Root maturation, of course, root maturation after regenerative endodontic is desirable. Okay. Although it has been shown that the increased root length of 76.2% and increased root width 79.2% of revascularization in immature permanent teeth. But studies have also demonstrated that root maturation is not predictable, because when we see in investigation, when we see in two-dimensional conventional radiograph, it might show complete root maturation. However, when we take CBCT, it reveals defective root development. Therefore, before any regenerative endodontic procedure, patients should be fully advised of the unpredictability of root maturation after regenerative endodontic of immature permanent teeth with necrotic pulp. This unpredictability of the root maturation are likely due to the disturbance in interaction between Hertwig epithelial root sheath and mesenchymal stem cell in the dental follicle. The severity of inflammatory apical lesion may damage or affect the function of Hertwig epithelial root sheath and mesenchymal stem cell in the periapical area. Or the stroma have a negative effect on the outcome of root maturation of immature permanent teeth with a necrotic pulp after regenerative endodontic, likely due to the damage to the Hertwig epithelial root sheath. Challenges in regenerative endodontics involve in disinfection of the root canal, removal of smear layer, appropriate corner seal, and also appropriate method to measure clinical outcome. Disinfection of root canal. It is crucial to disinfect the root canal in both regenerative endodontic as well as routine endodontic procedures to determine the success of the procedure. Sodium hypochlorite is widely recommended irrigant with concentration that is recommended is less than 1.5%. 17% ETA is recommended in regenerative procedure. It helps in the dissolution and release of impregnated growth factor in root dentin during dentinogenesis. This growth factor enhances the stem cell survival and its proliferation. Next, removal of smear layer. Although there is minimal instrumentation in regenerative endodontic, however, there might be still formation of smear layer. This smear layer will prevent the stem cell from adhering to the root canal walls, contributing to the failure of the treatment. Therefore, 17% solution of ETA as a final rinse in the root canal will aid in the removal of smear layer as well as enhance the attachment of the stem cell by providing a better surface on the root dentin for the survival. Other chemicals can be used for this purpose, such as doxycycline and citric acid. Appropriate coronal seal. Leakage-free coronal restoration is mandatory in RET. The material should be biocompatible, have to maintain cell viability, minimize micro leakage, provide adequate addition to the overlaying restorative material. Material under consideration are such as MTA and biodentin. Appropriate method to measure the clinical outcome. We have non-invasive tests such as laser Doppler blood flowmetry, pulse oximetry, lack of clinical signs symptom, and also radiographic signs like completion of root formation and disappearance of periapical tissue. This is to verify the vitality of the pulp. Pulp sensibility tests like thermal test and electric pulp tests are not reliable in checking the vitality because there is no conducting tissue in the coronal part. Clinical outcome defined by AAE. AAE define success by three measures. We have primary goal, secondary goal, and also tertiary goal. Primary goal is the elimination of symptoms and evidence of bone healing. It was reported that this goal could be achieved with high probabilities, 91 to 94% of periapical healing. Secondary goals, increase root wall thickness and also increase root length. It is also proven that RET has the potential to promote thickening of the canal wall and also continued root development. However, there is no proof that this increase in the increase in the root length and also thickening of the canal wall has an effect on the strength of the tooth. But they did a test on an animal study. It was shown that this thickening appeared to increase fracture resistance. The tertiary goal is to provide positive response to vitality testing. It is proven that positive response to the vitality testing reported was in 50 to 60% of published cases. The advantages is achieving continued root development. Obturation of the canal is not required, unlike in calcium hydroxide induced calcification. And also, after control of infection, the procedure can be completed in a single visit. The disadvantage is potential causes of failure can be due to poor root development because absence of increase in root length, absence of increase in root wall thickness, or lack of formation of the apex, insufficient bleeding during procedure, or root canal calcification or obliteration. It is a major concern that RET cause ground discoloration. Discoloration is more often associated with the use of minocycline and MTA. To minimize this risk of discoloration, biodentin instead of MTA can be used, and alternative for minocycline are cefaclor, amoxicillin, cefuroxime, fosfomycin, and androkitamycin. Discoloration can also be prevented by sealing the dentin tubules with dentin bonding agent before antibiotic replacement. And bleaching of the discolored teeth is an effective way to improve the aesthetic outcome. Thank you.